Morning, everyone. Thanks for coming to our session. I'm the moderator, and I will have no speaking part here. I'd like to introduce the speakers right now. First, we're going to have you hear from Dr. Jonathan Pan, who's an MD PhD, works at UCSF and has dedicated his professional life to investigating the mysteries surrounding spinal cord injury. And he is an anesthesiologist in a trauma center, so I guess he sees those patients as well on a daily basis. Next will be Dr. Claudia Clavijo. Their credentials are up on the slides. And she is really an expert in intraoperative monitoring because it's one of the few departments in the country, maybe the only one, where anesthesiologists actually are in charge of intraoperative neuromonitoring. Are you the only one right now?
I think so.
Maybe Northwestern as well. Anyway, she's also vice chair of community outreach and professional engagement, a practicing neuroanesthesiologist, and as I said, very involved in the neuromonitoring community and the governing bodies of the same. And she'll talk to us about how you address the systemic causes of neuromonitoring alerts in the cervical spinal cord interventions. And finally, and we're waiting for her to arrive, is Dr. Camila Esfahani, she's a practicing neuroanesthesiologist and currently in private practice in Fredericksburg, Virginia, previously at the University of Virginia. And she's going to talk to us about airway management and some current guidelines in cervical spinal cord injury. So I hope you enjoyed the session. We put in a lot of effort into making sure that we're up to date. And here she comes. Welcome, Dr. Esfahani, and we're going to start with Dr. Pan.
All right, good morning, everyone. Thank you for the introduction. It's my pleasure to be here today to present our recent work. So in this talk, I will briefly introduce the pathophysiology of acute spinal cord injury, and then why mean arterial blood pressure is important. And then I will show you our data by using machine learning on personalized hemodynamic management for SCI patients. And then some potential directions for future study. So as we know, a spinal cord injury causes loss of motor and sensory function and impairment of autonomic system, including bladder function and sexual activity. There are complete versus incomplete injury, and Asia grade here has been used as a common functional test to evaluate injury severity. For example, Asia A is severe and complete injury, and Asia B and C are moderate, incomplete injury, and Asia D is mild injury. As for the pathophysiology here, I just want to highlight some events, including after the primary injury. There is disruption of the spinal cord blood flow, which leads to tissue ischemia and hypoxia. And very often, there's also local hemorrhage. So all these factors can make the secondary injury worse. That's why early manipulation of blood pressure that can improve tissue perfusion and oxygenation could be neuroprotective and beneficial. As a matter of fact, there are clinical guidelines do recommend the use of vasopressors with a MAP goal between 85 to 90 millimeter mercury and with the treatment duration up to 7 days post-SCI. However, there are very little animal study and clinical human data to support such recommendations. So in our center, we aim to fill the knowledge gap in the clinical guideline. Therefore, we're interested in investigate the impact of MAP treatment in the spinal cord injury recovery in an animal model. So basically here, we use a rat, high thoracic, up to T3, contusion injury. And then you see this is the impact of the injury. And then we start the vasopressor treatment right away and continuously for 4 hours. And we have 3 blood pressure group. The one with the dark color is the normal pressure for rat. It's a mean arterial pressure of 100 millimeter mercury. And the hypertensive group is 130, and the lower pressure group is 70. And then at the end of 4th week, we look at different outcome. So as you can see, the normal pressure group, which is the dark color here, has a better motor function recovery compared to the other two groups. So is the injury area, the size of the injury area. The normal pressure group has a smaller injury area than the other two groups. And as of the bladder function, measured by the residual urine in the bladder after injury as an indicator for bladder function recovery. And then the normal pressure group has a better recovery than both the lower pressure group and the higher pressure group. And also at the same time, we also did a network analysis looking at a multi-center large preclinical rat SCI study. One of the findings show that actually higher MAP predict worse outcome in animal. So, so based on these very intriguing animal study, so then we want to use our existing human intra-op physiology data, and then by using the machine learning, we want the data to tell us, it's purely data-driven, tell us what's the impact of MAP treatment on the human spinal cord injury patient recovery. So we have intra-op hemodynamic data from 2 major trauma centers, from Santa Clara Valley Medical Center and Zuckerberg San Francisco General Hospital of UCSF. And eventually we have 118 patients for similarity network analysis, and we have 103 patients for regression analysis. So after the data extraction and curation, we apply different algorithms to basically reduce the dimension of the data, because it's a very high dimension data with a Q1 minute blood pressure and heart rate data. And then we'll build up a network that within the network, the patient is connected based on their similarity in their MAP values. So for example, each node here represents one patient. They're connected based on their similarity in their MAP. And then we try to cluster the patients with the similar MAP values together. Then we were able to reduce the network into eventually 11 clusters. And the size of the clusters is proportional to the number of patients inside the cluster. And then we did further exploratory network analysis, and then take this into an example. In this network, based on the MAP values, right? A number of the cluster of patients right here, these patients tends to have a normal pressure around 85, right? Based on the color you can see. And then there are several other clusters, including these 3 clusters with darker color. These patients tends to have a lower blood pressure from the color code. And then interestingly, there is an outlier here, a yellow cluster. These patients tends to be hypertensive, okay? Then we overlay the Asia grade improvement on the network. And interestingly, we see the patient with normal pressure, these patients, they tend to have a better recovery in their Asia grades, more than 1 grade, mostly. And then, as expected, the patient with low pressure, right? These patients, they tend to have poor improvement. And very interestingly, the patient those are hypertensive, they also have a very poor improvement compared to the normal pressure group. So then we further confirm our result by using logistic regression model. And also we further identify an optimal map range between 76 to 104 millimeter mercury. And I don't think I have enough time to discuss this algorithm in detail, but if you are interested, I'm happy to talk about this after the meeting or during the Q&A session. So for you to better visualize this relationship, here's the inverse U-shaped curve with the average map on the x-axis and the proportion of Asia improvement on the y-axis. And you can see that these are the lower and the higher limit, right? At 76 at the lower and the higher is 104. And then the patient within the map range fall in this range, actually most of them has a better recovery. However, the patient outside this range has a poor improvement compared to those with normal pressure. And the take-home message from this study is, not surprisingly, as we expected, all expected, hypotension cause, like the patient has low pressure, their improvement is poor. That's no surprise. However, what is interesting and striking is if the patient is hypertensive beyond some specific threshold, it can be detrimental. Okay? And further, I didn't show in the previous slides, is the time outside the optimal map range also is critical. The more time, the cumulative time, the patient's blood pressure is outside the optimal range, the poorer the recovery. Yeah. So besides this MAP treatment project, we also recently implement novel cord perfusion pressure protocol. It's with the goal of try to personalize the cord perfusion pressure for the patient in order to improve and want to see if there's any improvement in the neurological outcome. This is part of the CAMPER trial, and if the patient is enrolled, they will get a lumbar drain placement within 24 hours after spinal cord injury, and then we maintain the perfusion pressure above 65 for 5 days. And and then we collect the Asia grade upon admission and the 7 days after injury. And very interestingly, for overall, all the patients, we get more than 30% of successful conversion rate. Basically, they convert from more severe injury, like Asia B and C, convert to Asia C and D. And then for the more like moderate to severe patient, the conversion rate is even as high as 50%. Here is an example, the case that the patient came in with a C3 injury and with the loss of motor and sensory function below the injury level. And he received this cord perfusion pressure protocol and also an emergent decompressive spinal laminectomy. And he had significant improvement upon discharge. And several months later, he was able to walk with a walker. So although there are many factors involved in the acute spinal cord injury stage, and then also during the early care, but we still think that the personalized MAP treatment and cord perfusion pressure protocol holds great potential for improving patients' clinical outcome if properly combined with other emergent procedures like decompressive laminectomy. So potential directions for future. So first of all, it's very important for us to continue our multi-center study, which allow us to enroll more patients. Currently, we have more than 160 new patients so far. In order to improve our power of analysis and also to validate our previous machine learning models. And then another one is more interesting is using AI-powered modeling. For example, we can integrate biomarkers, which can be an indicator of tissue ischemia, neuronal injury, and neuromonitoring signals intra-op, and also intracranial pressures monitoring. Try to integrate these parameters into our treatment, for example, MAP treatment for the acute SCI care in real time. Last but not the least, I would like to thank our transforming research and clinical knowledge team, track and CI team at Brain and Spinal Injury Center at UCSF. It is a true collaborative team of multidisciplinary clinicians that work together during different care phases in our spinal cord injury patient, and also a group of neuroscientists and statisticians and even patient advocate to support our work. And last, I want to use this picture to wrap up my talk. This is a picture of conceptual model of machine learning for neurosurgical pathology. And each of these dots represent the data in a high dimensional data set, ready for us to data mine. And then they all point, in this case, to the cervical spine and allow us to evaluate the injury severity and the treatment efficacy for our patient in the future. And maybe next time, I'll bring you more exciting results from our AI study. Thank you.
Okay, in the interest of giving every speaker equal opportunity, we'll move on, and then we'll have questions and answers at the end.
Good morning. It is my pleasure to be here. I'm Claudia Clavijo, and we are going to talk about how and when to address systemic causes of neuromonitoring alerts. So our learning objectives for this second part are going to be to review common intraoperative neuromonitoring modalities, to also review their associated alert criteria, discuss the role of the anesthesiologist interpreting and managing alerts, understand different types of alerts, and some factors that can influence those signals, and also explore briefly some strategies used in the OR when we have alerts. Somatosensory evoked potentials are used to evaluate the functional integrity of the somatosensory system and for early detection of impending or injury to prevent permanent damage. As you can see on the picture, this is an example of left and right, upper and lower extremity somatosensory evoked potential. These are reliable signals. The distance between the positive and the negative deflection is called amplitude, and the time when these responses appear is called latency. Traditionally, alert criteria for SSEP is being a decrease of more than 50% in signal amplitude and an increase of more than 10% in latency. Recent guidelines also call our attention to those signals who have very minimal variability. For those signals, you should not wait a 50% reduction to call the alert. For those patients, maybe a 30% reduction may be significant. This is an example of an SSEP alert. You can see for the left upper extremity, baseline responses are the traces in black, and you can see how during the case, those responses, traces in blue, are completely gone in the cortical and subcortical channels. This met alert criteria. Motor evoked potentials are used to evaluate the functional integrity of the corticospinal tracts. They allow for real-time assessment of evolving injury and also to evaluate perfusion. Remember, MEPs are very sensitive to the effect of hypotension and also to the effect of anesthetics. Alert criteria for MEP is based on 4 parameters. The first one is called all or nothing. An example you can see on the right side on the image. You can see at baseline reliable responses in red for all muscle groups. During the case, you can observe how for the right lower extremity, those responses were completely gone, so all or nothing. The second one is based on amplitude reduction, but what percentage of amplitude reduction represents an alert is controversial. Some authors recommend 80%, some others 50% reduction, but also depends on the type of surgery you are doing. The need to increase stimulation by 100 volts to obtain a response similar to baseline or a morphology change, a signal that was complex, polyphasic, and now became monophasic or delayed, also alert. When you are planning your anesthetic for a patient who requires neuromonitoring, ask yourself this question: who is your patient? Someone young, healthy, athletic, or do I have someone who is elderly, debilitated, and frail? For the second patient, responses may be more difficult to obtain and more difficult to maintain throughout the case. It is also important that we remember the effect of our anesthetics on the different modalities. We all know that MEPs are affected by inhalational agents and nitrous oxide. However, SSCPs can also be affected, particularly in those with very weak signals at baseline. Propofol helps preserve responses, but boluses or deep level of anesthesia interfere with responses. Opioids have minimal interference. Neuromuscular blockers affect both MEPs and EMG. Ketamine helps preserve responses. Several studies have reported the negative effect of dexmedetomidine on MEP amplitude. And about lidocaine, we don't have strong data to make recommendations. However, at regular doses, it seems to be acceptable. So during a spine surgery, alerts can be triggered by many different factors, as you can see on the slide. Most common surgical factors include compression, retraction, trauma, or vibration. Our anesthetics, some of them, as well as profound anesthesia depth, can interfere and trigger alerts, as well as other physiologic factors such as hypotension, hypothermia, anemia, hypoxia, and lately there are reports of reperfusion after severe decompression of stenosis. Positioning can also be a source of alert or some external factors. Let me show you some examples. So this study compared the rates of false alerts on MEP in patients receiving inhalational agents versus TIVA. And they show significant higher rate of false alerts in patients presented or exposed to inhalational agents compared to TIVA. And this was true for patients with previous deficits as well as those with no previous deficits. This is an example of interference of desflurane with SSCP amplitude. So you can see baseline responses were obtained on propofol, and desflurane, 1/3 of a mag, was added to the propofol regimen, generating decreasing amplitude, increasing latency that met alert criteria. This study compared remifentanil desflurane versus remifentanil propofol on effect on MEP amplitude. You can see at the top, the desflurane group, you see significant reduction in amplitude, while on the propofol group, you have preservation of those responses. As mentioned, several studies have reported negative effect of dexmedetomidine on MEP amplitude. This seems to be dose dependent. These patients require higher stimulation dose, had higher rates of false alerts, and it was determined that dexmedetomidine was a confounding factor. This is especially true if you bolus the patients or if you have infusions going at high doses. Probably lower doses that are constant without bolusing could be okay for patients, especially those who are neurointact. This is an example. Look at the top of the graph. MEP responses that were achieved on propofol remifentanil. You can also see reliable SSEP. Dexmedetomidine was introduced around here, and you can see MEP responses are gone with preserved SSEPs. Dexmedetomidine was stopped, and then you can see how signals return, but it took about 45 minutes from them to return to baseline. And this is actually one of the patients that I was supervising the neuromonitoring for. Please pay attention to the responses in green. They were obtained at baseline in all muscle groups, reliable. And then please switch your attention to the responses in blue, the lines on top of the baselines. These were obtained after a bolus of dexmedetomidine was given. You can see absent responses, you can see reduction in amplitude, and you can see also change in morphology. Ketamine has been recognized as a medication that helps preserve responses. A recent Delphi consensus study recommended the use of ketamine in infusions when you are doing MEP monitoring, not only to help with pain management, but very important, to decrease other MEP suppressing medications, including propofol. So when alerts happen, this is time for everybody in the room to stop and connect. Neuromonitoring team members should alert not only the surgical team, but the anesthesia team about the alert, and they should immediately rule out technical issues. Surgical team should focus on the most recent surgical intervention and determine if this could be contributing to the alert, and if so, if this is reversible or not reversible. Reversible, take action, remove the screw, release the rope. If this is non-reversible, for example, a contusion on the spinal cord, we all together need to decide if it's safe at this time to improve blood pressure, perfusion pressure map, and if it's also safe to continue at this point. At this time, the anesthesia team should be focusing on two important areas: change in pharmacology, change in physiology. This is our area. So change in pharmacology, someone came, accidentally gave medication that is interfering with your responses, or change in physiology. We have a drop in the map. We have to evaluate our oxygen carrying capacity, temperature, oxygenation, ventilation, and our electrolytes and pH, the homeostasis. It is important to remember that surgical alerts tend to be more localized, while these alerts generated by changes in physiology or pharmacology tend to be more generalized or global. This is what we follow at the University of Colorado. We all stop and we turn the music off. This is time to pause and connect. All team members look at their respective areas for possible contributing factors. We rule out technical problems. Surgical team evaluates the last intervention, and we will determine if this is contributing, if it's reversible or not. At the same time, we focus on pharmacology and physiology. Is the homeostasis preserved, or do we need to intervene? If we found a surgical reason for this alert, we consider together if it's safe for this patient at this time to improve our map and to add additional medications. Positioning also should be reviewed. We learned on our first talk an important aspect of blood pressure management. There are no guidelines that you can find in the literature, but the message is the same that we've heard on the first talk. So hypotension is not good, and hypertension is also not good. So what we want to understand is where we need to keep our patient, how safe it is to go lower on the map, and how high are we gonna let it go. So these recommendations say don't focus on a single number. Evaluate your patient for comorbidities, the extension of the injury, the physiology that you are seeing, and let your blood pressure go no lower than 75 or 80, but also don't let it go above 95 or 100 of MAP. Blood pressure MAP above 100 of MAP hasn't proven to improve outcomes, and on the contrary, a lot of complications due to the use of vasopressors have been described. The goal is normothermia, anemia correction. The numbers that you find in the literature are probably around or above 8 for most patients, but individualize this goal according to comorbidities, according to the response to stress. Some patients may need higher hemoglobin. And how are all the additional factors involved in the physiology of this patient? Improve oxygenation, normocapnia, pH, electrolytes, blood glucose should be between 140 and 180. Hyperglycemia is deleterious for neural tissue, as well as hyperthermia is. In conclusion, SSEPs and MEPs are commonly used in cervical spine surgery to prevent permanent neurologic injury and also to prevent extension of injury. What we do matters. Anesthesia team plays a fundamental role in the preservation of responses and in alert management. This is an invitation for you to get more connected to the neuromonitoring modalities and the team in the room. Our anesthetics could negatively affect evoked potentials, and remember, they can also be affected by hypotension, anemia, hypoxia, and hypothermia. Thank you.
Hello. I'm Dr. Esfahani, and my title is The Final Word on How to Manage the Airway in Cervical Spinal Cord Injury. I have no disclosures. I would like to thank Dr. Jackie Marino, for whom I'm substituting today, and she helped with the PowerPoint slides. The learning objectives for this talk are going to be that we're going to review the incidence and causes of cervical spine injuries. We'll talk about the airway management in the acute spinal cord with a focus on the cervical spine, look at the evidence for spinal cord immobilization and our current practices, and then we'll talk about a circumstance where immobilization may hurt rather than help. Traumatic spine injuries carry significantly high risks of morbidity, mortality, as well as have exorbitant healthcare costs for associated medical needs following injury. The annual incidence in the US is about 40 per million of the population. Of these injuries, many people survive, leaving over 250,000 persons in the United States living with spinal cord injury. And it equates to about 12,000 cases a year. When we look closer, about half of these patients have isolated spinal injuries, but about a quarter have additional trauma to the brain, chest, or major extremities. And violence-related acts contribute to about 15% of them, falls 27% of spinal cord injuries. Sport injuries contribute about 8% of spinal cord injuries, with the majority, the leading cause being motor vehicle collisions. And then there's a smattering of other causes making up the rest. And as anesthesiologists, we are often called into these cases right at the intersection of chaos: multiple injuries, unstable physiology, and the need for airway control. And when we talk about spinal cord injury, we have to remember there are two mechanisms: the primary mechanical insult and the secondary injury that follows, driven by hypoxia, hypotension, and inflammation. And here's the part where we have the biggest impact: preventing or aggressively treating that secondary injury, as my prior colleagues have talked about. It's why airway management, oxygenation, and hemodynamic stability are so critical in the early period. And before we do anything else, we must stabilize using the ABCD approach: airway, breathing, circulation, disability, because that's what can help prevent secondary cord damage. Let's talk about the part we all think about, the airway. The ideal intubation technique for someone with acute unstable cervical spine injury remains controversial. On paper, the answer is easy. You intubate quickly, you avoid hypoxemia and hypotension, and minimize movement of the cervical spine. But that's the oral board's answer. In reality, the choice of how to intubate depends on what's in front of you: the setting, the patient's injury, the available equipment, and frankly, your own experience and skill. And it's important to remember that about 1/3 of patients with cervical spinal cord injury will require intubation within the first 24 hours. And these patients can deteriorate fast. They're at high risk of airway compromise for multiple reasons: neck trauma, soft tissue edema, hematoma, bleeding, and of course, loss of diaphragmatic and chest wall function. When the injury is above C5, ventilation is already impaired, but at C3 and above, patients will lose respiratory control entirely. And without pre-hospital intervention, they often arrive in respiratory or even cardiac arrest. So as anesthesiologists, we will ask the question, can't I just intubate? Can't I just go ahead and secure the airway? And Crosby and colleagues, Crosby talked about this in his review, looking at various studies that looked at cervical motion during the 3 phases of direct laryngoscopy. And here's what he found. So inserting the blade caused minimal motion. Elevating the blade for visualization caused the most movement, as we can all imagine, especially at the atlanto-occipital and atlanto-axial joints. And passing the tube added only a small additional movement. And then Hinman and colleagues created a cadaveric model of type 2 odontoid fracture and measured intervertebral motion of injured cervical segment and found truly no significant difference between these models, the healthy spine model and the injured spine model, when it came to extension, canal space narrowing, or force applied. And here they used 2 different blades or airway techniques: an air track, or a Macintosh blade. And while the air track contributed to the minimal force applied and the Macintosh blade was supposed to represent high force, there was still no difference between the models. So if the blade elevation is where most motion occurs, then the natural question to follow is, how can we limit that? So one of the things that came up in the 1980s that was very popularized, it came up earlier but really came to fruition then, was manual inline stabilization or immobilization, MILS or MILI. And this was really taken up by the Advanced Trauma Life Support Guidelines and continues to be used today during intubation to minimize secondary injury. And there are 2 ways you can perform this technique. You grasp the side mastoid process and the occiput, or you have someone on the side cradling the mastoid process and occiput. And when MILS is in place, the anterior portion of the cervical collar can be removed to allow for greater mouth opening. So Monsu and colleagues studied 76 healthy volunteers and found that when you put on a cervical collar, the mouth opening does drop from about 4.3 centimeters to 2.6, and the number of difficult airways jumped dramatically from 16% to 91%, and neck extension was cut in half, from 44 degrees down to 22 degrees. So immobilization can protect the spine, but it also makes our job a lot harder. MILI improves visualization, but doesn't make it safer. So Majernik and colleagues demonstrated that MILI reduced, or manual inline stabilization, reduced total spinal movement during the process of laryngoscopy and tracheal intubation, more so than cervical collars alone. However, this study was performed in healthy volunteers. So the next scientists asked, what about in spinal cord injury models? So in a cadaver model with complete ligamentous instability, Lennerson and colleague reported that application of Milli minimized distraction and angulation at the injured level, but had no effect on subluxation at the site of injury. And then Gerling and colleagues compared direct laryngoscopy in patients with manual inline stabilization and with patients getting a cervical collar, and this was an unstable cadaver model. And they found that Milli reduced motion by about 2 millimeters compared with collars. Whether that's significant clinically is a different question. So we have to remember most of these studies are in healthy volunteers or cadavers, not in the real world patient with an unstable spine. And since then, we've also developed more tools, most notably the widespread use of video laryngoscopy. So then the question is video laryngoscopy more effective? Can we just use that to solve the problem? We know that the degree of neck extension depends on the user and device used, and that the Macintosh blade produces the greatest neck extension, up to about 25 degrees. Video laryngoscopes like the GlideScope do improve glottic visualization when we're using manual inline stabilization, but they don't eliminate neck movement. So a study using fluoroscopy showed that GlideScope reduced motion at C2 to C5 by about 50%, but there was no change at C1 to C2 or occiput to C1. So it's not motion-free, and if you don't know the exact level of fracture, video laryngoscopy isn't necessarily safer, it just shifts where the motion occurs. Focusing now on the goal of minimizing time to intubation rather than just movement, a Cochrane review looking at various types of video laryngoscopies showed that VL is likely to reduce the risk of a failed intubation and increase the chance of first attempt success compared to direct laryngoscopy in patients with a C-collar or manual inline stabilization. Comparatively, now the question comes up, why not use a sleep fiber optic intubation? Well, it had a reduced impact on upper cervical motion. It did increase the time to successful intubation compared to video laryngoscopy. And then Schottker and colleagues were able to perform actual neurological assessment using SSEP, somatosensory evoked potential. They looked at 40 patients with traumatic cervical spine fracture using either a sleep fiber optic or air track, and they found no significant changes in SSEPs with either technique. There was one patient in each group that had changes, but overall no significant changes. And moreover, they found that patient positioning had a much higher incidence of SSEP changes than our impact of tracheal intubation. When we look at Harborview Hospital, which is a level 1 trauma center in Seattle, they looked at the incidence of harm from various techniques. They had 252 patients with cervical spinal cord injury. They used primarily video laryngoscopy, did some fiber optic, direct laryngoscopy was minimal, and then the combination of them. And they found that there were no cases when they followed up with the patients of neurological deterioration secondary to airway management. And so the theme here overall is providers should use the intubation technique with which they have the most comfort and skill. When the ASA closed claims database was reviewed, they found 37 spinal cord injury claims, and only 9 of those had documented instability. And in just 2 cases, airway management was thought to contribute to neurological deterioration, both done without manual inline stabilization, I might add. So while neurological injury from airway management is rare, it's nearly impossible to determine if one approach is truly safer than another. And most of our data are cadaveric, retrospective, or from normal volunteers. So although spinal immobilization is typically effective in limiting motion, it has been associated with morbidity in a small percentage of cases, particularly when additional head injury exists in patients with ankylosing spondylitis and in the setting of polytrauma. Cervical collars are also associated with elevated intracranial pressure, and spinal immobilization in general has been connected to increased risk of pressure sores, aspiration, and limitations in respiratory function. And that leads me to when should we really not use cervical collars when we're intubating. And that's one important exception, penetrating trauma. A large study of about 45,000 patients showed that immobilization in penetrating trauma actually doubles mortality, from 7% up to almost 15%. The number needed to treat for cervical immobilization to actually be effective was 1,032, and the number needed to harm was 66. Why? Because immobilization delayed resuscitation in these patients. So in penetrating trauma, skip the collar and manage the airway directly. So is this really the final word? I think in medicine we can never really say. But to conclude, there's no single perfect technique. Use the method you're most skilled with to ensure that the patient has adequate oxygenation and that you maintain hemodynamic stability, as my prior colleagues have talked about. And you want to minimize cervical motion as much as possible. Every tool, direct, video, fiber optic, comes with trade-offs. What matters the most is that we anticipate, prepare, and prioritize oxygenation and perfusion. Because at the end of the day, our goal isn't just to secure the airway, but to avoid secondary injury and making that salvageable spinal injury from becoming a permanent one. Thank you.
We have plenty of time for questions. Can you use the microphone? I will start with the question of Dr. Pan. So, vascular people have used spinal CSF drainage, lumbar drainage for years as in an effort to forestall complications from spinal cord perfusion or hypoperfusion. What are your thoughts on that? And is there anything to suggest that maybe a corollary between your work and that very completely empirical information that we've had for years?
Yeah, so, yeah, I mean, that's true. But for traumatic spinal cord injury, this is totally new. We are still in trial. Actually, our trial will end the end of this year. And then we'll have, so the data I show is only like 15 patients. So this is completely new. And then we were not only try to reduce the ICP by draining, but also we collect the CSF and then for biomarker study as well. So just for multiple purpose. I think in spinal cord injury, I think the data show that it's helping. And also, apparently, we can refer to the reference or the evidence from the vascular surgery field, and then the spinal protection by the lumbar drain. I think that's area we should refer to and look into the more evidence to support.
Please.
Thank you for the presentation. My name is Demisha Rank, and I'm coming from The Ohio State University, where I primarily practice neuroanesthesia. And I don't know if it is truly a dying art or just something that I personally enjoy, but that is the awake fiber optic. And I noticed that it wasn't necessarily something that was offered as something to consider in these patients in these high cervical spine injuries. So I guess, what would you offer as something to consider in terms of considering an awake fiber optic for these patients? Of course, considering all the other risks, aspiration risk, positioning challenges, cooperation, but just wondering where that fit into the plan of identifying how to best secure the airway.
Is this thing on? Thank you. That's an excellent question. And I intentionally didn't bring it up because awake fiber optic is the safest way to go, right? And all the literature talks about how the standard of care in the past was to do an awake fiber optic intubation, but it's not necessarily the only thing to do. Your patients are going to be critically ill potentially, and like you mentioned with full stomachs or maybe altered mental status, elevated ICP, other issues, polytrauma going on. it's going to be very difficult to do an awake fiber optic. So I wanted to emphasize with my lecture that video laryngoscopy is an excellent alternative, and potentially just as safe. And time is something we want to consider when we secure these patients' airways. So you're absolutely correct. Awake fiber optic is a perfect choice. But you have to think about everything else within that context.
Thank you.
Can I add something else? It is also important to recognize the technique that you are more skilled at. And some people may not do enough fiber optic intubations to feel comfortable to manage an emergency situation. So I think that I agree with your concern. We should be doing it more often to be ready for when these emergencies arise. If you don't do it enough, this is probably not the best time to try, as we heard from Camila.
And also, I have one comment also. And and some of these cervical spine, like spinal cord injury patient, they actually are intoxicated or they're not awake. So like you probably want to, awake fiber is the safest way, but you want to also consider like aspiration. So you probably want to secure the airway as soon as possible. So that's the balance.
Good morning, Joseph Drinkard, LSU Shreveport. I had a question about the neuromonitoring. Two quick questions. What, in your experience, do you consider a high dose of dexmedetomidine as an infusion? And then in the figure that you presented where after a dexmedetomidine bolus, we saw these changes in the motor and somatosensory. In your experience, how long does it take them to return after a bolus of dexmedetomidine?
Thank you. Very good question. So the literature says that signals, this is a dose-dependent effect, and that you start seeing reduction in amplitude with plasmatic concentrations greater than 0.6 microgram per ml. However, this is not very practical in your clinical day since we don't do targeted control infusions. So basically, it's really hard to guess. The patient that I did received a dose of 0.5 max per kilo. And you saw the dramatic change. It took us 45 minutes to recover, and we were in the middle of the most critical part of the procedure. This was a patient who had AVM, and we were doing the embolization trial. And we lost the responses right towards the end. So we had to stop and wait for the dex to wear off. There are reports, though, that say that lower doses, probably less than 0.5 max per kilo with no bolus, just lower infusion rate may be safe. I cannot tell you if this is safer in patients who are neurointact or maybe some with some injury may be more affected. We are not there yet. What I have seen in my experience, the 4 or 5 patients that I have similar results have been boluses, even lower doses than the 0.5, but a bolus. And then the 4 patients had some mild neurologic deficit.
Yeah, Chapman University, New Mexico. I have a somewhat polemic question about blood pressure management. So most of the time we manipulate blood pressure with norepinephrine. And so my question for you is, to what extent do we know that we're not self-deluding ourselves? Is it actually improving capillary bed perfusion, or do we get a precapillary increase in blood pressure and actually capillary starvation? Turning the question around, is there a better agent, maybe vasopressin superior as a post-capillary vasoconstrictor? Any data on experimental setting that you would have?
That's a good question. We remember the animal data I showed. We actually use norepi. Actually, these days, because of some of our work, we actually switch the first line vasopressor used from dopamine, phenylephrine to norepi. These days, norepi is the first line. I think because the patient with unknown cardiac history. So that's why we switch significantly to norepi more than before. Vasopressin, that's a good question. I'm not sure about the physiology behind it. But consider it, because some of our patients are elderly patients, maybe with unknown cardiac issues. I think norepi in this case is more, for healthy patient, right? Young patient with traumatic injury, I think either one is okay, not necessarily to be norepi. And also higher, like cervical and high thoracic, norepi is the first line. Yeah.
Hi, Rafievich. Excellent talks, thank you. Should agree with our colleague from Ohio State that flexible bronchoscopy should at least be mentioned, including the combination methods in line with other methods, especially video laryngoscopy together, as well as a staged intubation with a supraglottic airway, since you can do a flexible bronchoscopy through that and intubate. Now, not all cervical spines are unstable, but I had one publication about concerned ones, that you're concerned if you do a certain level of movement, there may be something in there. Now, except for C3 and C4 compression fractions, I believe supraglottic airways are a good method, at least to start a ventilation. I wanted to ask your opinion on that.
Yeah, so the studies have compared, looked at the different techniques, right? They'll compare direct laryngoscopy, LMA intubations, combination and such. And those are all good options and safe options. There'll be minimal movement with LMA as well. The question that you have to consider is time. And that's why the emphasis of the talk was, what technique are you most comfortable with doing so that you can secure the airway in a timely fashion with the least minimal movement, because it is truly dependent on how much you are comfortable with your technique, if that makes sense. There was little movement at the upper cervical spine with most of them, so occiput to C2, and then the greatest movement was around C3 to C5. And that was worse with direct laryngoscopy, but when you compare video laryngoscopy with intubating LMAs or CMAC and fiber optic, they were all pretty much millimeter differences, but not enough for us to say, does this have a clinical impact?
Last question, please.
Last guy knows right on the board. Quick comment and then a question. I remember reading a study with mask ventilation having more cervical spine displacement than the actual laryngoscopy too. So I think if you're messing around with a technique, it might be better just to go for it. It was like 3 millimeters versus 1.5 millimeters with mask ventilation versus laryngoscopy. But my question was with the BIS monitor and ketamine, and if that you use ketamine during your technique, if it invalidates your 2-digit score as far as knowing if a patient has consciousness.
We hate that number.
Yeah, no
Yeah,
number.
Don't pay attention to the number. Please ignore.
Good session later on this afternoon.
Go ahead and focus on your raw EEG. It will tell you more information. What we also recommend is that you don't use ketamine in boluses throughout the case or high doses. You should use this in this setting in subanesthetic doses just for analgesia, and it's better to use it as a constant infusion since the beginning than bolusing throughout the case, because you will see a change in a spectral array on your EEG. That is correct. So, but focus on the number, plan your anesthetic in a way that you have minimal changes throughout the case, especially during critical portions. Your anesthetic shouldn't be adjusted. You shouldn't bolus propofol. You shouldn't bolus ketamine. You shouldn't also add ketamine without reducing your propofol. Remember, one of the benefits is to be able to decrease MEP suppressing medications to preserve responses so that they are reliable during the most critical portions of the surgery.
Thank you.
Yeah, a plug for the session in the afternoon about is EEG just a number? I encourage you to attend. Thank you very much for active participation. Thanks.